My name is Dr. Rachel Truchil, and I'm a primary care doctor at Penn. I treat a lot of patients with severe substance use disorder, but I see even more who occasionally will use stimulants such as cocaine and methamphetamines. I think patients who use cocaine and methamphetamines can sometimes make us anxious as primary care doctors because we're not exactly sure what to do. And I think sometimes just telling patients that this can be really bad for their health and can have bad health consequences doesn't really get us very far. But I think heart health is really our bread and butter, stuff that we do every day. And so I think this is an area where we can really have in-depth conversations with patients who are using stimulants to help improve their health. Stimulant use causes an increase in norepinephrine and catecholamines that the body is exposed to, and this causes vasoconstriction. This makes the heart work a lot harder and can cause a lot of cardiovascular complications. In the acute setting, we know this can be very dangerous and can lead to an increase in heart attacks, strokes, and hypertensive complications. It's also dangerous in the chronic setting as well, as it can lead to a progression of atherosclerotic disease and LV hypertrophy. It's really important to assess a patient's stimulant use history so that we can fully assess their risk of cardiovascular complications. Traditional cardiac risk calculators don't include stimulant use in those calculations, but this is something that we can add into our histories to get a better picture as to what the risk is for our individual patient in front of us. When patients are using stimulants and I'm thinking about their overall cardiovascular health, I tend to be more aggressive in my risk factor management. When thinking about their lipid profiles, I'm much more aggressive in starting statins earlier for these patients so that I can reduce their overall cholesterol levels and improve their risk. I'm also more aggressive in my management of their high blood pressure. I start conversations about treatment of hypertension earlier, even if their blood pressure is only mildly elevated, and I tend to treat to get their blood pressures even lower. I'm also more likely to think about additional testing when these patients come in with symptoms that could be related to underlying cardiac disease. So if patients who are using stimulants come in with atypical chest pain, I'm much more likely to want to get stress testing or coronary calcium scores to see if they may have evidence of ischemic heart disease. If patients who are using stimulants come in with shortness of breath or evidence of hypervolemia, I'm also more likely to order an echocardiogram to see if they may have evidence of an underlying cardiomyopathy. In my practice, when I have a patient who's using stimulants, I actually use it as a mental cue just to remind myself to think about their cardiac risk and to review this with them on a frequent basis. Just having an overall awareness of the effects of stimulant use on the heart can help our patients to be as healthy as they can and really to reduce their overall risk of heart disease in the future.